afternoon. It is a pleasure to welcome you to the American Association of Kidney Patients 38th Annual Convention. We are so glad so many of you were able to join us here in beautiful Little Rock, Arkansas for what promises to be a weekend of education, patient-to-patient interaction, and fun. More than 40 years ago, a group of 6 dialysis patients started a support group to allow fellow kidney patients to communicate with one another. They wanted to share their experiences with one another. They talked about medications and new therapies. It was an effort to let other kidney patients across this great nation know they were not alone in their fight against kidney disease. A few years later, the patients started meeting in one location. They were able to put a face to the names and stories that they had heard about in newsletters, newspapers, and magazines. Today, the board of directors, staff, and volunteers of the American Association of Kidney Patients continues in their tradition of bringing patients, healthcare professionals, and friends of the kidney community together to shed light on the increasing epidemic of kidney disease and to share our experiences that allow fellow patients to live more productive lives. Again, I thank you all for being here this weekend. If you have any questions or concerns throughout the weekend, please see a member of the AAKP staff. A staff member is always at the convention registration table, which is right here on the second level outside the Hoffman and Manning meeting rooms. I want to thank our convention sponsors. Their generous support makes it possible for us to host this event. And thank you to our exhibitors. The exhibit hall will open at 4:30 this afternoon in salons A and B. Please visit the exhibit hall often this weekend. The very knowledgeable vendors have information on products and services that make our lives easier. Now, please welcome Karen Wiles, AAKP's Executive Director.
Thank you, Carolyn. Boy, I don't know how many of y'all were down at the Public Policy Forum, but I hope those of you who went enjoyed it as much as I did. I certainly want to extend my thanks to all of you who decided to join us this weekend for this very important patient meeting. This event, as you can imagine, is a huge undertaking, and as I look at everyone here today and more that will come in even tomorrow, I can say it's well worth the effort. I want to thank, as Carolyn did, our convention sponsors. Your generosity is more than appreciated. I also want to thank the exhibitors and encourage all of you, both patients and healthcare professionals in the audience, to take advantage of the exhibit hall, which will open today at 4:30. Please visit the exhibitors, see the wonderful products and services that they have available. I also want to thank the City of Little Rock, Bob Adler, the host committee here. You've provided such a warm welcome to the AAKP family and have been so kind to us, our staff and our volunteers, and we're very excited to be here. I may have to get a part-time home here and just come back. I also wasn't written into my remarks by the staff because the staff writes remarks for us to say, but I also want to thank the wonderful staff. They have done a tremendous job of putting this together, and as some of you may know from last year, I've only been here a year, so I'm still learning, but thank goodness I've got them walking behind me, because if I didn't, I wouldn't be standing up here today. Yes, thank you. Just as it's done for 38 years, AAKP hopes to facilitate and foster an atmosphere of community and collaboration here in Little Rock. From the beginning, as Carolyn said, AAKP has been the go-to patient voice in the kidney community. showing all of you patients that you have a voice, and you do have a very loud voice in your treatment choice, on your health team, and certainly in Washington, D.C. And as you learned this weekend, and as we started today, we're going to start raising that voice in Washington, D.C. The same is true today. I invite you to not only explore our website, aakp.org, but to determine how you can be a part of our mission. Give our office a call. Any of our staff members, including myself, answer the phone, and we would be more than happy to talk to you and discuss your concerns or needs. For those of you who have never been to an annual patient meeting, this meeting features a rich selection of educational sessions today, tomorrow, and Sunday, led by renowned healthcare professionals and patients. And like many of you, I'm eager to engage with patients, and certainly the professionals, through the sessions and through the informal opportunities that we'll have tonight in the welcoming ceremony, and then all day tomorrow, the lunch with the experts discussions, and then our big banquet tomorrow night. With more than 20 educational sessions over the course of this weekend, this is the time for you to gain firsthand knowledge about your health care, to learn about the latest research in kidney care, and most importantly, to learn from each other, fellow patients. Taking part in your care is a key to leading a successful, healthy, and productive life. I am very proud and very honored to be a part of this dynamic network, this dynamic organization, grateful for the opportunity to explore with you how we can all continue to improve the lives of kidney patients around the United States. Thank you again for being here. Welcome to Little Rock, and I hope you enjoy every aspect of the weekend.
At this time, I'd like to begin the conference with our first session titled Patient Advocacy, How to Make Sure Your Voice is Heard. On the panel today are Dr. Barry Straub, and if you would, come forward. Dr. Straub is the immediate past Chief Medical Officer for the Centers for Medicare and Medicaid Services, as well as the immediate past Director of CMS, Office of Clinical Standards and Quality. In his role as the most senior clinical advisor to CMS, Dr. Straub and his office spearheaded key initiatives including Medicare coverage, decision-making, multiple national quality improvement collaboratives, CMS clinical quality measurement and information technology efforts, defining quality standards for U.S. healthcare facilities, the development of value-based purchasing models and implementation of many sections of the Affordable Care Act of 2010. Dr. Straub also chaired the End-Stage Renal Disease and Clinical Laboratory Open Door Forum and acted as a senior advisor on ESRD and transplantation issues to the agency. Dr. Straub retired from CMS in February 2011. He now serves on the board of Next Stage Medical Incorporated. Our next panelist is Brian Hess. Brian is a kidney disease patient of 23 years, a dialysis patient for the last 14 years. He currently uses peritoneal dialysis as his therapy. He recently graduated from the University of Central Oklahoma with a degree in biology. He serves on the Patient Advocacy Committee for ESRD Network 13, as well as the Quality Improvement Committee from Network 13. Next, we have Mary Jane Ashworth King. retired registered nurse from Lewisburg, Pennsylvania. Mrs. Ashworth King is a chronic kidney disease patient who has been active in the kidney community for the last 6 years. And finally, we have Paul T. Conway. Paul is a transplant recipient from Falls Church, Virginia. He is president of Generation Opportunity and former chief of staff at the U.S. Department of Labor under Secretary Elaine Chao. Mr. Conway also serves as the vice president of the AAKP Board of Directors. Now we want to ask our speakers to be mindful of the time, and I'll help you. Because we want to leave at least 15 minutes at the end so that there can be questions and answers from the audience.
So Carolyn, thank you very much, and good afternoon to all of you. It's nice to see a number of folks that I've met over the years, but many of you I do not know, and I look forward to getting to know you better. One of the advantages of retiring from CMS is that I can now devote more time in the communities and actually say what I believe all the time rather than having to watch my words carefully. I still have to do that, but maybe a little less so. What I'd like to do is to try not to take up too much time actually because I'm most interested in hearing from the other panelists and from those of you in the audience about issues of patient advocacy. I think this is one of the key core roles of AAKP that I think is so essential. I've admired for a number of years, and I hope to be supportive in this arena more than I have been able to in the past. I'm a nephrologist. I'm a transplant physician by training before I worked at CMS. And this is an area, no matter what I get involved with going forward, that I am going to be very active with. So what I wanted to start off with is what I often get asked, what's it like back in D.C. right now in terms of the political arena and the advocacy arena? And this slide shows you 2012 countdown to Armageddon. This is not far off from, and you've seen this over the last several weeks with the budget ceiling raising debates and so forth. But it goes far beyond that. This was starting a year or two ago, actually several years ago, the debates that were had over the Affordable Care Act and other health care issues over the last several years were presaging, I think, what we're now facing going forward. And as another example, you may not be able to read this entirely, but it says ends of the earth, and you can see a volcano exploding, the shifting of the poles. Little did I know when I chose this slide to put in here that a couple days ago we did have an earthquake back in D.C., Baltimore area, Virginia. Although my primary home's in San Francisco, so this was small potatoes compared to that. But this does depict, these two slides, I think, what we're facing and is one of the reasons why patient advocacy is so important. One of the things that I want to spend a couple of minutes with is impressing upon you all and giving you a little background. Some of you know this, but probably many of you are not fully aware of how complicated the federal government in particular is in terms of its health care provisions. And what I've listed here are some, not all, but some of the major healthcare federal stakeholders that have some participation in healthcare law, healthcare regulations, and the administration of those. And you can see I've highlighted the Department of Health and Human Services because that's where I worked, and we'll drill down into that. But as you can see, many other departments, including the Department of Labor that Paul worked for Secretary Chao there, and many other areas that you wouldn't think have a major role in healthcare regulations. It's important to know this because sometimes these other departments and agencies in fact have a major role that you're just unaware of. They may be able to put a block on legislation or put a block on some policy that is working its way through policy approval, regardless of which party is in charge of the executive branch or the House or the Senate. So it's good to get to know these, but obviously because of health care, a good deal of the focus is in the Department of Health and Human Service. So what's the Department of Health and Human Service? Sounds like this nice big department, but not only is it big, but it's very complicated also. So I've listed for you here just some, not all, of the various agencies and offices present in HHS, if you will. And I'll highlight a few of these that I think are most important to keep track of. You can see that I've italicized the Centers for Medicare and Medicaid Services, or CMS, where I worked, and where I think much of the activities that affect kidney disease, and in particular end-stage renal disease, occur within CMS, as you are probably well aware. And CMS, just for background for you again, provides health care benefits for over 114 million Americans this year. I've listed for you the breakdown by the three major programs that CMS has traditionally administered, Medicare, Medicaid, and the CHIP programs. And you can't just focus on Medicare, although that's the primary program that affects renal disease in this country. You do have to focus, as those of us who were able to attend the Public Policy Forum this morning know that Medicaid and the Children's Health Insurance Program, or CHIP, have an effect too. These three programs consume this year over $784 billion in expenditures, and I've broken that down for you also in terms of dollar amounts. And interestingly, because of the Affordable Care Act, CMS also, for a number of reasons, was given the responsibility for oversight of the Office of Consumer Information and Insurance Oversight, which is setting up the insurance exchanges that will be available for those people who are uninsured and unable to get medical care in the United States if the Affordable Care Act goes through to its full implementation. That's going to be another 30 million patients. So CMS is involved with public and private insurance manifestations now. And even if it doesn't oversee all of the private sector, whatever CMS does, in fact, affects the private sector. They often adopt policies of the federal government and so forth. I put the last bullet here. Again, many of you are probably aware of this, but I can't tell you how many times I've told senior leaders in the Department of Health and Human Service about this last bullet, and it doesn't seem to penetrate. Less than 1% of Medicare patients who enjoy the benefit of Medicare coverage for ESRD consume fully 6 to 8% of the total Medicare budget. So it's a huge part of the Medicare program, and yet many folks in D.C. are not aware of that. They fully don't understand how much money is involved, and they also, unfortunately, don't always understand some of the clinical issues and the effects that it has on patients and their families and the entire economy for those who get it. CMS is involved with provider payment issues. It's involved with beneficiary-focused activities, which include education about what benefits people are entitled to under Medicare, Medicaid, and CHIP, as well as increasingly educating folks about how to use those benefits to their best advantage to make their health better and to live longer and to live healthier. The biggest area that I was involved with, which I think has seen the most change, is the area of quality, efficiency, and value promotion by the federal government. So this is an area where advocacy needs to also get more and more involved. And as a sideline, I have a fourth bullet there, data collection. CMS has a tremendous amount of data. The data that it's collected over the years has been underused as it is, and there's far more data that's going to be available with the onset of electronic health records, personal health records, and other electronic data collection methodologies. So you'll see a lot more with CMS and HHS providing data, holding people accountable for the care given to patients with renal disease. So when I first did the next several sets of slides, I just wanted to list for you what I thought and actually much of the next section here has to do, having given you an overview of what's involved at the federal level, it's who are the people that you need to target for advocacy purposes. And I put this down initially as targets for advocacy, and then I thought about that and was thinking that, gee, they're not really targets unless you don't get done what you want to get done. They're really partners. They should be partners. So I prefer to suggest and encourage you to think of all of these entities as potentially partners, but if the first two slides I show you come about, Armageddon, etc., they become targets, and then we have to be a bit more forceful in dealing with a much more serious situation. Obviously, in the federal government, the Congress is the first partner or target mechanism, and I've listed for you here, when you take the entire House of Representatives, the two committees that have most input for renal disease are the Ways and Means Committee and Energy and Commerce committees. So I spent a lot of time on the Hill with staff and with principals from these two committees in the House, and simultaneously in the Senate, it's the Senate Finance Committee and the Health, Education, Labor, and Pension Committee also in the Senate. There are a variety of caucuses. There is a renal disease caucus, dialysis caucus that's present up there with representatives who are from both the House and the Senate who are interested in renal disease. I think we had a session this morning on health disparities, and I find one of the most vocal set of caucuses that help for renal disease are, in fact, the minority caucuses, the Congressional Black Caucus, the Hispanic Latino Caucus, and the Asian Pacific Islander caucuses. These often have great influence and interest in renal disease issues. Well, that's the Congress. Then there's the White House. And of course, I worked, being part of the Department of Health and Human Services, worked for the President in the executive branch. And there are many senior advisors there, and one can benefit by getting to know at least some of those. And that's done through your leadership, through Karen and the board of directors and the staff at AAKP. But sometimes these folks are from your own states or your own communities, and it's good to try to seek them out and try to influence them directly. Also affecting the White House is the Office of Management and Budget, which gives approval for any budgetary issues that eventually go over for legislation to be done. So OMB is another important area to try to get to know people and to talk to them. Well, within the executive branch agencies working for the President, I gave you a list of those, and under the U.S. Department of Health and Human Services, I've listed for you here those agencies and centers that are most important concerning renal disease. CMS is the greatest, but AHRQ, CDC, FDA, HRSA, NIH, and the Office of the National Coordinator, which is setting up health information technology, is very important also. These and many, many other agencies that I mentioned earlier do have influence over kidney disease, but if you have to concentrate on any one, it's CMS. Within the Centers for Medicare and Medicaid Services, obviously the administrator, I used to report to the administrator, gets most of the final decision-making ability, although is heavily influenced by the secretary and people above him or her. But within CMS itself, there are actually four main areas you need to know about, and again, to work with and or through to try to promote renal disease issues. The Office of Clinical Standards and Quality reports to the Chief Medical Officer, so this was an area that reported to me. And I've listed to you the various functions that OCSQ actually is involved with, but it's probably that office which has the most involvement with renal disease, and it was very fortunate from my standpoint, and I think the agencies, that I happen to be the rare occurrence of a nephrologist who happened to be in the position overseeing these important areas. The Center for Medicare has the payment area, very, very important area. They determine what providers of care, whether it's dialysis units, physicians, nursing homes, etc., are actually paid to provide services to patients with renal disease. The Center for Medicaid does affect the Medicaid programs, although it varies from state to state. But the important part of the Center for Medicaid is that they have oversight of the state survey agencies and the regulatory oversight processes. They're going in and evaluating dialysis units, transplant programs, hospitals, and other facilities of care. So they're very important to get to know. And then last but not least, and I think many of you are fully aware of this, the regional offices, there's 10 of them. These are areas which often can intervene on more local problems that need more acute or sudden resolution. So it's good to get to learn about them. I skimmed over in OCSQ, one important area I would be remiss not singling out are the quality improvement organizations and the end-stage renal disease networks. Both of these deal with renal disease. While I was in place, we expanded the quality improvement organization involvement with renal disease to chronic kidney disease, and the networks look at end-stage, particularly care delivered in the facilities. And then, of course, there are many, many others: state governments, dialysis providers and organizations, professional associations. There's the organization Kidney Care Partners, which Karen and I have talked about, and I believe, I would guess that the Board of Directors has talked about relationship to that. I won't go into great detail. There are private health plans, there's other patient advocacy organizations, and I left off on this slide another important one, and that's the manufacturers, suppliers of equipment and supplies for dialysis, and pharmaceutical companies that provide pharmaceutical agents. All of these are involved with determining the fate of patients with kidney disease. So a few personal notions. I use the word notions because that's implies more that this is my personal quirks. You may or may not agree with this. But first of all, you need to know the framework of the regulatory system that affects you and the people who run it and work them. And we don't have time to go into the lawmaking process, but you need to get involved and learn how laws are made and regulations are made. Advocates can and do have major influence over the federal framework, and that is through the federal rulemaking process. And I gave an example here, a number of slides which we won't cover each one, but the recent passage of MIPA, the Medicare Improvements for Patients and Provider Act of 2008, set up the bundled payment for dialysis facilities. And if you look at the payment structure, there was a number of things that were proposed. The NPRM is a proposed rule, proposed in the bundled payment system. Quickly go through these. And there were significant public concerns raised when these were put out for public comment. This is the prime time for all of us, whether we're part of an organized advocacy group or individual citizens in the United States, to comment on what is contained in these rules. So AAKP, many individuals in this room, professional associations, etc., commented on it, and the end result was that the final rule for payment to dialysis facilities under the new bundled payment system with a quality incentive program tacked on were affected very definitely. I saw that firsthand by comments all the way from, again, massive organizations down to individuals like all of you in the room here. When you do go in, some advice. Written comments are always helpful. On important issues, I would suggest you try to meet personally with folks. I would anticipate, certainly at CMS, some skepticism to whatever it is you are coming in to talk about. Try to get beyond that. Try to get beyond the obvious attitude of people saying no, or we can't, or don't do that. Stay calm, persist, explain the situation, and people will start to listen if you can do that. Criticism is helpful, but I think trying to have an alternative or a solution to what's been proposed is very helpful. If you just come in and say, you're crazy, you can't do it, it won't work, people will listen to a point about that. But if you have an alternative and it's been well thought out with evidence, that can be very helpful. I think coming in as groups is often more helpful than coming in certainly as an individual or an individual organization. And I think that trying to build this collaborative approach that I hinted at with the federal agencies, trying to be partners as opposed to choosing them as a target can really help you. Now, I did want to mention, in addition to federal regulations and laws and what the federal government does, the media plays a significant role, some good, some bad. Increasingly, I think it's often good. And I don't know how much aware you are, but this was in reference to an article last November in the Atlantic Monthly that got published. And this was the title of the article, "God Help You, You're on Dialysis." And you can see the schematic here with a patient at a dialysis unit who's all tied up with blood tubing lines and other things. And what happened in this article was that the reporter, and she interviewed me as well as a lot of other people, reported on the fact that 100,000 patients begin dialysis each year, but 25% will die within the first year. This rate is significantly higher than other developed nations. She pointed out that we spend $25 billion a year in the end-stage renal disease program, $77,000 per year per patient for hemodialysis treatments, which exceeds other countries by far. She alleged, and it was partly correct, although I wouldn't say hiding it, but data exists on patient care, and the federal government perhaps doesn't publish and promote this evidence and information as much as it should. And from my vantage point, more importantly, we don't always act on it as much as we should. Patients commonly, she said, receive treatment in clinics that are, quote, unsanitary and prone to perilous lapses in care. And although this does happen, I've seen it, I think she went a little bit too far in suggesting that every dialysis unit in the country was unclean, with blood all over the floors and people dying every day within the units. But there are problems in dialysis units. She pointed out, this is true, regulators have few tools. We don't have enough budget to oversee all of these units. And that's denied us by the very legislators who, in fact, criticize us when we don't pick up the problems. So we need to, there is a problem with regulatory oversight. And then she brought up another very important issue that I'll throw out for comment by people too, but industry consolidation has left patients with fewer choices of providers. Two corporate chains currently do predominate, treat nearly 70% now of dialysis patients, making about $2 billion of operating profit per year. And there's an increasing emphasis on acquiring private pay patients as opposed to Medicare patients by these. Problems persist for years. They're often ignored. That's somewhat true. And as to quote a friend of mine, Tom Parker, who's a Dallas nephrologist, we're offering our patients therapy we wouldn't accept for ourselves. More and more leaders in the field are starting to say this isn't sufficient. So I'm going to close, as I see Carolyn standing up for the second time, and thank you, Carolyn. Just some regulatory issues that I'm very curious as to. That's my timer too, Carolyn, for the 20 minutes I thought I had. Just some things that clearly folks have to do something about, whether it's at the federal level, in private industry, and so forth. There's payment system reform. There's quality measures development. Which quality measures do you want to know about, let alone should be developed? There's public reporting. What should be reported publicly? What do you all need to know about to choose the dialysis unit you go to, the physician you go to know whether the care you're getting is good or bad or not? What data should be made available to everybody? What about future regulations, the priorities and needs? How are providers being overseen, and are they being overseen sufficiently? How about electronic health records and personal health records that patients should have? What's going on with those, and how will they serve your needs best? In coverage under the Medicare and private programs, how much should comparative effectiveness and cost-effective analysis play a role as we go forward? A huge debate the country has not had. Clinical issues. What about fluid control? How do we define adequacy of dialysis? In the wake of a recent change in the FDA for ESAs, erythropoiesis stimulating agents, there's grave concern by many folks that people will underutilize ESAs and will go backwards in time to undertreatment of anemia. Home dialysis, frequent dialysis. availability of transplantation, pediatric dialysis, which is a whole world unto itself, gaps in preventive services, compliance with medications, which is notoriously horrible in the renal world. The challenging patient. What about the patient who some people feel is acting out and others feel are being heroic and bringing up problems that no one else is able to say without fear? What about the functional status and patient experience? And what about end-of-life and palliative care issues? There are some times when we should be talking about whether continuing dialysis is good or bad. There's other issues, the media, as I've already alluded to. What about social media applications? My iPhone here, there's all sorts of wonderful apps. What kind of applications can be helpful for advocacy, let alone for patient care? Collaborative efforts, what about the role of KCP in the dialysis units, etc.? And what does this consolidation lead to? These are just a few of my thoughts. Thank you for taking the time to listen to them, and I'm very interested in what my colleagues up here will have to say about their experiences. Thank you.
Well, as you've heard, there are many ways that we can advocate as patients. From my experience, I've come across many on my own personal level that I wanted to share with you. The number one thing I would say for someone in my situation is be willing to seize opportunities. The big thing with advocacy is getting your voice heard. For some patients, they might think, well, I don't have any experience doing something like this. How do I go about doing some kind of advocacy? For me, I just started sharing what I had to know, my own story with other people. Along the way, I came across a nurse who was involved with Network 13. And after talking with her, she recommended to the network that I become part of their Patient Advocacy Committee, or PAC. At that time, I was very willing to become part of the PAC, but was still new. I didn't know what I was doing at most, but was willing to listen and learn and help where I could. In time, they asked me to do more, to volunteer other ideas and of myself. And this led to me being able to come and attend the convention with AAKP 2 years ago. I again was able to just share my story with more people and come up with more ideas of things I could do. I was even encouraged to look into speaking at that time. And since then I've been able to do more public speaking and have enjoyed it. On my own time, I've also tried to find ways to do things that might be a little different than what I'm used to, but also enjoyable for me at the same time, such as charity events. Locally, you can probably find all kinds of different things that are charitable. For me, I love bike riding, so I look for bike riding charity events. In my local area, I took part a few years ago in the Tour de Cure, which works with diabetes research. Another year, I rode in something called Spin Your Wheels, which works with the Children's Center in Oklahoma City, helping disabled children. Both of these things, I was one person among a multitude, but still, every one of those people is a small advocate for whatever you're there for. They need everyone there to make the difference that they're trying to do. One way or another, the first thing you just got to do is make yourself heard, whether it's one person among many, or one-on-one with a nurse in your dialysis unit, talking about something that you think needs to be fixed. It's advocating whether you're in a large group or not. It just matters that someone is willing to listen. It is important that the people in DC and our politicians hear what we have to say, but sometimes we can make differences on a smaller level as well. Just in your own unit is probably the easiest way to start off if you're a patient. Just advocacy wherever you can find it. In my own case, I started out small, and one thing has continued to lead to another, to where I can do public speaking, but I can still go back and do those small things. Just have to keep going, and do whatever you can, however you can. Advocacy can take many forms, and that's my experience of it all. Thank you.
Hello, I'm Mary Jane, and I'd like to thank Carolyn and Karen and Jerome Bailey and Diana Kleins for including me on this distinguished panel. I really am honored. I was invited to speak because of my participation in the Capitol Hill Day Advocacy event, a joint venture that's sponsored by the Renal Physicians Association and AAKP. Simply put, I'm here because I answered an email from Jerome. Earlier this summer, I received his email through AAKP's listserv, inquiring if anybody would be interested and available for a visit to Washington, D.C. Being both interested and available, I sent a reply. First, let me tell you a little bit about myself. Professionally, I'm a registered nurse. Medically, I was diagnosed with chronic kidney disease in April of 2006. Advocacy, personal and professional, has played a very significant role in both of these aspects of my life. Patient advocacy is an essential part of my professional history. It is what nurses do. The profession compels individuals who I feel by their nature are called to be caregivers, to use their gifts to help those who are medically vulnerable receive the attention they need. It can and does include going to bat for your patients and standing with them and their families throughout their experience. It's a very real definition of advocacy. My personal advocacy took on a whole new meaning when my young husband was diagnosed with a particularly virulent form of leukemia. At that time, advocacy was perhaps limited to each individual case. Kidney transplants were relatively new, and dialysis was still being debated on late-night talk radio shows that kept vigil with me. Those discussions usually consisted of various callers, enumerating the pros and the cons of being kept alive by machines or the ethics of using other people's organs in an effort to maintain your own life. I found these particularly intriguing and annoying, both through his illness and his death. We would have gladly accepted any treatment that would have given us just a few more minutes together. I remember thinking of the people arguing so very vigorously against such life-saving measures, thankfully, had never been touched by the quiet desperation that comes with the hope of just one more treatment, one more chance. I hoped then, and still do, that they have continued to remain untouched. Like many of you, I was shaken by my diagnosis of kidney disease 5 years ago. My experience as a patient with CKD began the day after a routine physical. I was shopping with my daughter for her wedding dress when I received a call telling me that my blood work needed to be repeated. Having delivered news just like this many times in my work, even using the exact same phrase, I knew this meant something was hinky. Something was not right, and I was fearful. A diagnosis of chronic kidney disease, late stage 3, helped to kind of ease my anxiety a little bit, but that was going to take 4 or 5 months. And during that time, I obviously struggled with the news, but I also began to view myself as my own advocate. I was not satisfied with the care I received under my initial nephrologist. All my prior experience with patient advocacy focused upon myself as I sought care and a more definitive diagnosis from the best source that geographically happened to be close. And for me, that meant traveling to the University of Virginia School of Medicine, where I was treated by Dr. Klein Bolton. He made a studied and careful diagnosis. He started treatment to stabilize my disease and attempted to prevent further deterioration. I've since moved to various states, but prior to each move, I've diligently researched and asked my current nephrologist for recommendations on who my future nephrologist should be. This has led to a wonderful experience at Duke and currently at Geisinger Medical Center in Pennsylvania, where I currently live. It was in Pennsylvania when I first spoke with Jerome, and he told me the purpose of the D.C. visit. I warned him of my inexperience in public advocacy, not to mention my complete panic at the thought of navigating notorious Washington, D.C. traffic. I was brutal in my assessment of what I perceived to be my limits for my contribution, especially my fear of driving on the Beltway. These fears were eased by Jerome's kindness. Jerome, apparently, being fearless himself, asked me to participate anyway, and even included my husband at an invitation to a dinner hosted by AAKP the night before the event. I was stunned, and yet I immediately accepted, thinking, now this could be fun. Not only will I get a chance to see the nation's beautiful and sometimes dysfunctional capital, no offense, folks, I'll get a nice hotel room, free eats, and get to roam the hallowed halls of Congress. Knowing I lacked a lot of knowledge specific to kidney issues currently being drafted or debated before Congress, I set out to learn as much as I could. There are many websites that are devoted to kidney patients and professionals that offer tremendous amounts of information. I researched some of the congressional committees and healthcare agendas, and for the first time realized that Congress actually formed a bipartisan kidney caucus that was established in 2002. Bipartisan, unheard of. I looked up my state senators and representatives' websites so I could familiarize myself with some of their agendas and goals regarding the healthcare issues. And the more I read, the more I became aware of really how very little I knew, and the more interested I became. I was hooked. However, I did find one speed bump in my learning curve, which is abbreviations and acronyms. Now, you would think that acronyms would be nothing new for me, given my background, but the government ratchets this form of communication up to a whole new level. I mean, I found 2 entire pages on just one website that was single-spaced, listing the acronyms and their meanings for congressional departments, offices, and current legislation. Yes, it was intimidating. But I also came to realize that exactly why such a list exists. It's to allow a private citizen to participate in the dialogue by learning the language. Now, once my husband and I arrived in D.C., we attended the dinner hosted by AAKP. And it was then I finally got a chance to meet Jerome, as well as Karen, the executive director, and a small group of the friendliest and most outgoing people. Each was an AAKP member, a fellow kidney patient, each in differing stages of their disease and treatment, and each with a unique story that's bound by that common thread of kidney disease. The next morning, at the Renal Physicians Association breakfast, I was able to say hello to my diagnosing physician from UVA, and also discovered that my current nephrologist was accompanying me to one of my scheduled congressional visits. It was like an old home reunion weekend. I had no idea that any of my nephrologists were involved in matters of public policy or patient advocacy. After breakfast, we gathered for a meeting covering the nuts and bolts of the protocol for a congressional visit. We were given handbooks and maps and schedules. The handbook and schedules were invaluable. The maps were wasted on me. I tend to get lost very easily. Just ask my husband. It's a skill, really it is. During our brief meeting, we were given advice on how to approach various discussions and how the exchange of business cards was Washington's true gold standard of currency, and that the email was the preferred method of communication. It was a brief and intense education. I felt nervous and excited, and yet at the same time amazingly prepared. I met my first RPA partner, and we left for our visit within the hour. My initial partner was a most friendly and personable physician, having copped to my complete inexperience in anything political. He took me under his wing. We had 2 visits that morning, and the experiences were very different. The first went extremely well. The legislative aide seemed genuinely interested and engaged in conversation. Walking away, I remarked to my partner on how the aide seemed to be very, very receptive. He replied that he also thought it had gone well, but sometimes that's not always the case. True to his word, the second meeting was a bit tense and awkward. The aide seemed to switch between indifference and defensiveness. It was weird and thoroughly uncomfortable situation. Upon leaving that meeting, I looked at the doctor and said, I can see what you meant. And we both kind of laughed. We knew we'd given it our best shot. The third meeting was with my current nephrologist, and surprisingly, I was more nervous for this meeting than I was with any of the earlier meetings. I wanted to do well for my physician. You patients know what I'm talking about. You want your doctor to respect you, and you want him to think you're not an idiot. Thankfully, that legislative aide was completely engaged, and the meeting went really well. In truth, I was really glad that the meeting had included a clunker because I was able to really gauge the value of it all. At that point, came home, I was exhausted, absolutely exhausted, but I was so very excited. And we went ahead, we were encouraged to send emails. And it's not merely because it's good form, but they allow us the opportunity to remind the recipients of the goals that we had during our visits. So it's a little bit intimidating writing notes like these, but at the same time, there's an awful lot of areas that you're able to, the resources out there, they're out there. You just have to look and find them. So, and also, this is where you get to cash in that currency that you earn through the exchange of the business card, because you've got that little card and now you have their individual's phone number and their email address. So it's the working ways of capital. But I've gained so much from this experience, and it's led me to wonderful new friendships, travels throughout the hallowed and impressive halls of Congress, and now here to Little Rock at the National AAKP Convention. It's also led me to seek out and continue to have additional knowledge of legislation that can affect kidney patients, to stay on top of the pending issues, and to make my voice heard. And I learned when Jerome emails, you really should reply. But in closing, advocacy brings a sense of empowerment. It's both personal, when you're forging together with your physician a plan for your physical health, and public, when you're joining in the dialogue of the legislative care for disease. When you or a loved one is diagnosed with a disease, like it or not, you are thrust into the position of an advocate. Embrace it. Run with it. Make it work for you, for the betterment of whatever situation you may find yourself in. Let it build in you that sense of empowerment. And when that occurs, everybody's going to win. Thank you very much for your time and attention.
I guess I should say I'm from Washington and I'm here to help, but I will say this. I have had the good fortune to be active in public life and work for some very principled people over time. And I have a lot of friendships both sides of the aisle. And I want to give you a couple of different points that I think will be helpful. And then also I put together a sheet as a practitioner of politics of top 10 things you can do at a different level of thresholds. So, you know, things you want to do immediately that are easy, and if you want to get more involved that you can. And I have a copy with Jerome. We'll make a copy of that available for you. But let me give you a couple of highlights on things. Basically what you've seen just up on this panel is a very good flow chart of how the federal government works and how Congress works. You've heard talk about the media and how you impact that. But probably the most important thing that's sitting in this room in this entire discussion is you. Because you went through the experience, you lived the experience, you are the embodiment of what the American taxpayer spent a tremendous amount of money on, and you are what is relevant to those in the political process about what works and doesn't work in kidney disease. And you need to remember that, because you can have the best political consultants and the best advice, but the best credibility you have going in the room is yourself. And it won't matter how articulate you are, what will matter is how passionate you are and how determined you are. That's what will make it. But let me just read you one quote that I think kind of sums up a lot of what we're talking about here. It's about impact. It's John F. Kennedy. The ignorance of one voter in a democracy impairs the security of all. And what I would tell you is that you have multiple constituencies that you need to educate. You need to educate those who are in the political process, you need to educate those who are in the media, and you need to educate those around you, those who actually vote on issues that matter and impact you. Now, the good doctor here mentioned the fact that the Armageddon and the deadlines that are coming up, I think some of us have opinions about investing into 6 elected officials, the decisions that you actually elected an entire Congress to make a decision on. But where we are in this country right now with great debt and these types of things is that an accommodation has been made. And whereas you have elected 100 senators and hundreds of representatives to make decisions for you, there's a process now where 6 individuals have been invested with the weight of those decisions. Why does this matter to kidney patients, and why must your voice be heard now? It's because the very programs that those folks will consider and talk about and discuss and recommended changes to are the very programs that are the reason why so many of you are here in the room today. That's a fact. I wouldn't be here. I'm 14 years out on my kidney transplant. I did 2 years of dialysis and I had a 13-year decline. On the professional side, I've worked on over 100 political campaigns. I worked for 4 presidents and 3 governors. So being part of the problem, I understand that. But I can tell you this, that we are members of a constituency that has disproportionate influence because every day we deal with the issues of life and death. And I think that at CMS, when people like us come in the door, and again, it doesn't matter how sophisticated you are, the fact is that you are living it every day. You are not a concept. You are reality. And when you sit down with somebody, whether it's the lowest legislative aide, whether it's the lowest member of your state House of Representatives, remember, you have disproportionate impact. And the 10 points that we will give you to take a look at are things that allow you as one individual to radically amplify your voice. Let me just take one example. How many people here know what social media is or Facebook? Just out of curiosity. Okay. There's a generational trend. How many people know what Twitter is? Okay. Now, how many of you actually use those things? Okay. Now, here's a little statistic. I notice, I have an organization that I started less than a year ago. We're now the largest social media organization in the country, next to the White House. But we will soon eclipse them. And we're bipartisan. And we deal with issues of unemployment and economic opportunity because we actually care about that. But I can tell you a lesson from that organization. Nearly every individual who's on Facebook has an average of 385 friends on Facebook. Now, you may not, but the key is this: grow your network. Because you never know in the other person's inbox, so to speak, how many people they can influence. And where this comes into play is this: it's exponential numbers. So if you go out and you do a speech and you talk and you have a Facebook page, put it up there. Go talk to a reporter. If a reporter covers it as a personal interest thing, if it was, like World Kidney Day or something like that, get to know your local reporters. And in this guide, we have how you introduce yourself and that type of thing. But all you need is one little story, and then you put that up on your Facebook page, and you ask your friends, hey, put this out. It's exponential. You want to personalize the story of what's going on with you. And then you want to call up your elected officials and start at the very representative in your state, and then at the state level, go to state senator, call your local offices of congressmen and senators, so that when they come home on vacation and they come home on breaks, part of their job is they work for you. So if they can't meet with you, their staff will, and you need to personalize your story. In my experience, both sides of the aisle, only the most crass people, and I'll be honest, there are some, only the most crass people will not listen to you, but more often than not, you're actually educating people because they deal with programs and concepts they've actually never seen the beneficiary of it. So in their head, sometimes they don't even know how to conceptualize it. It was interesting, the story that was told up here. One person kind of got it, and one person was kind of defensive. Well, sometimes you're defensive if you've been advocating cutting something. It's very easy to do with an eye shade in the spreadsheet, but when somebody comes in and sits down in front of you, and their life or their passing is determined by your elected representative, the person you work for, you have a whole new take on it. Let me tell you. The reason why AAKP is relevant to this is because we can provide you tools and the targets for how to be influential. We can tell you the meetings that are coming up that we need you to have a voice in. But the other thing is this: we are the only patient-centered organization that's there. Meaning, we work in coalitions with many groups, but we are beholden to no one. Just patients. That was the original design for this. So while we will work alongside providers, we will work alongside pharmaceutical companies and others, and they will sponsor our events, we are a patient-centered organization. What that means is, when we say something, people listen to us. They look at who we act in coalitions with. But if we speak on our own, they still listen to us, because our agenda is about the patient. And how you can play a role in that is seek out your local reporter, seek out your local cable access. Talk radio, let me tell you, it can be kind of crazy, but the fact is that local cable access, local reporters, and local talk shows, it's a competitive world. I know this really well. They look for content. 24 hours a day news cycle, and nearly every one of those outlets has its own blog site or Facebook page, and they are starving for content. The best content at a local level, probably summed up best by Tip O'Neill. You can see my father was a Boston Irish Democrat. Man, did he wear his eyes when I worked for Ronald Reagan. But Tip O'Neill said all politics is local, and he had it right. Because if you have a human interest story, get that out there at the local level. And before too long, when we go out and we do different events and things like that, people will have an interest in you at the state level. And then if you're talking to the local affiliates or the local representatives of your federal representatives and senators, you may actually get a call sometime, hey, we read that story, you would be a great witness on this program. You'd be a great expert at the State Assembly when we have this hearing. And I would encourage you, don't worry about it. Just keep it real. Just go say it in your own words. Because people just need to hear how regular people get impacted. I've worked for a lot of different folks, a lot of bullet points, a lot of talking points, structured meetings down to 7 minutes, 12 sides, that's the President of the United States. 12 sides, 7 minutes, that's it. Done. Meeting, 40 meetings a day, something like that. But when somebody sits down and you're out there in the field and they just tell you how they lost their business in a hurricane or whatever, when people go back, that's actually what they remember. And more often than not, that's what they'll actually act on. They'll be like, wait a minute. Remember when we were in that town, that person approached us and their dialysis center wasn't clean? Or they had a concern because somebody was bleeding out? What about that? What are we going to do about it? That's what compels people. So what I'm telling you is never underestimate the power that you have. Never, ever underestimate the power you have. And if you have a network of folks, just start with your Christmas card list. Start with your kids. Start with your friends and let them know what you're going through. And ask them to repeat it. Because then they're all like transponders of your story. And your impact is significant. So thank you very much for being here and for listening.
Now we want to take questions from the audience. If you have a question, would you raise your hand? Any questions from the audience?
I just have a comment. I just have a comment. I picked up a flyer in one of the dialysis units and saw the American Association of Kidney Patients, and I thought, August, 95 degrees. That's how hot it is where I come from, so why would I want to do that? Well, because I am the educator in the office for CKD patients. I have already invited congressmen down to a dialysis center because I work with the American Nephrology Nursing Association. And you know what? Elections are coming up. They'll be glad to come down and visit your dialysis center. That's their constituency. And just get a few facts together, or just introduce them to some patients. And the other thing I'd like people to do is go back and say they want a nurse practitioner in their unit. There is a shortage of nephrologists, so if you feel like you don't see a nephrologist enough, or he's not there when you need him, there is a real shortage of nephrologists. So if you have any contact with universities at all, go visit the School of Nursing and let them know how exciting nephrology nursing is. If anybody says they'll lose their skills in the dialysis unit, it's because they're not doing their job.
Thank you, Carol. Thank you, panel. I'm Linda Tyler. I'm state representative and on the AAKP board from Arkansas, and I just want to say welcome to all of you who are here. Dr. Scott, I wanted to ask, as we continue to look toward healthcare reform in our state, particularly in 2013, we're looking at a $60 million shortfall in Medicaid, 2014 a $200 million shortfall in Medicaid. And that includes what's coming with healthcare reform. We're doing a lot of talk about team care, accountable care organizations. If you are keen for the day, and I know you're not, I'm not keen for the day either, but if you were keen for the day, how would you structure that ideally to make sure that the patient is at the center of that?
Well, is that better? No. Can you hear me now?
Yes.
I think the first thing is that kidney disease is a prime area for where you could set up accountable care organizations that are specialty focused. And in my design, I would make it that you'd have an accountable care organization that wouldn't just be a dialysis unit and a nephrologist involved, but you'd have an organization where you'd have nephrologists, chronic renal disease care provision, which would include not only in-center dialysis, but home dialysis in all its manifestations. It would have transplantation services present right there in the same location. You would have chronic kidney disease, at least the later stages of it, in that one center. You'd have physicians, but you'd have the nurse practitioners and the other important people, the dietitians and the social workers and all the other people who are involved with this team kind of approach. But you'd include as part of this, and some of the legislation, the Affordable Care Act, some of the special projects that ensue under that kind of get back at medical homes and accountable care organizations have to do with the governance structure. So I think a key part of this is going to be having governance structures that include representative of all those people who are working within the accountable care organization, but very clearly include patients and their families to have a say in the governance of how these organizations get run. So that would be my quick version.
I just want to thank Steve Farmer from Houston. I'm very, very honored to be here and to be able to witness this. I think right now we're in an incredibly turbulent time in healthcare, and the costs of running dialysis programs are going up. I often feel in a dialysis unit that it's basically that we've commoditized something that is a miracle, and yet, I mean, when I think of commodities, I think of soybeans, and we're not soybeans. And so I think as patients and as physicians and as providers, the most important thing that we're going to have to do is recognize, just like someone said earlier today about the tree stump, that we're going to have economic pressures. It's there, and we're going to be forcing ourselves to improve. And it means that patients are going to have to get involved. You're going to have to get involved as advocates. You're going to have to demand excellence. And you're going to have to not only demand it from other people, but you're going to have to demand it from within yourself. I don't think it's appropriate for a doctor to have to tell a patient to take their binders. I think that if somebody tells a patient that if you don't take your binders, and some doctors don't bother to tell you, which is a problem in and of itself, but once the doctor explains to the patient what the consequences of not doing something are, then the patient who cares about themselves needs to be taking the initiative to take care of themselves, and not because of the doctor, but because they want to get well. To me, if you can demonstrate to your doctor and to your providers and to Congress what people like Peter Lundin and Bill Litchfield demonstrated before Wilbur Wills in the 1970s, we won't have the problems in healthcare that we have right now. But the challenge is on all of us. It's not on me, it's not on you, it's not on the dialysis companies, it's not on the government. It's on all of us together. There's plenty of blame and there's plenty of opportunities. So I think we should really work together as a team on this process.
Any more questions from the audience?
My name is Pauline Bowers. I'm from California. I have chronic kidney disease in 35 to 40%, and have had it for a couple of years. I was diagnosed a couple of years ago. I have had a really difficult time finding out what to eat. I live in an urban area with nephrologists. I've seen 2 nephrologists. I can't find a nutritionist that will give me a hint, or even the types of foods I need to do. I did go to a dialysis center and got the little pyramid to have a general idea of what I shouldn't eat. But I really need more education in that part to prolong the amount of time I have before I have to go on dialysis. And I think the education when you're first diagnosed is really important, because the longer you can sit off of dialysis, the longer that you don't have to pay all the money, and the expenses are a lot less in the care. But I would like to, on that comment, have some information about that.
Can I answer her question?
My name is Carol Marie Waterlander Futner. If you remember me from years ago, this is my husband Bill now. Now, my doctors in Ohio, many years ago, gave me papers, my nephrologist, and said, this is the diet you follow. They have the phosphorus, okay, they have the highs and the lows, the proteins, and what to eat, what not to eat. I had a fistula on my forearm in 98, kidney problems in 97. I was not on dialysis for 3 years. Okay, because of the strict renal diet. Now, why these people are not giving the information, I don't know. It is there.
Something I'd like to say, just briefly. In my time working with the Patient Advocacy Committee with Network 13, we talk about how badly education is needed all the time. Last year, I came to the realization I've lived with my own disease for 23 years. I've learned the education firsthand, and I'm trying very hard to do something on that right now. I'm actually in the editing phase of getting a book done that hopefully will be published by the end of this year that basically tells you all the needs to know when you first get diagnosed with end-stage renal disease, because I know patients want to know, what do I need to know about diet? What do I need to know about caring for my access? Am I on the best type of dialysis for what fits my lifestyle? You're right, education needs to be out there, and this is one small thing I'm just trying to do to help. But it is another thing that we need to work on just in advocacy alone, is getting the education out there wherever we can.
I have a twofold question. At my center, they've been talking about bundling, and you mentioned bundling. Where can we go to find out a detail of what bundling means?
The most obvious place to go first would be to the cms.hhs.gov or the cms.gov website. And if you put in dialysis bundled payment in the search form, you should be able to get to a site there. I don't know if AAKP has a summary of bundled payment for dialysis.
Okay.
And on the bundles back in late March, March 31st, and I believe that's on our website.
Okay.
And if you go to aakp.org, you can listen to Dr. Jay Wish and Beth Whitten talk specifically about the bundle. And it's a very informative, and we'll do more about that because dialysis centers have asked us to provide more information to you all as the patients about the bundle, and this is good for me to hear. So we'll be glad to do more.
Because they say all the time, we're bundling, so we can't do this, we can't do that. So we really need to know what bundling means. And the second part
Can I just add one thing on follow-on to that first part?
Okay.
If you go on the AAKP site, and Jerome or somebody can show you where it is, you can actually see what AAKP weighed in on in the federal process, so you can understand from a patient perspective where we had a problem with it.
Okay.
And we got active on it, and it's a very clear statement, and you can say, oh, wow, they were objecting to this, and you may actually now say, now we're actually seeing it at the point of implementation, which would give you an opinion that's expert that you need to tell people.
Okay. And then the second part,
If I could too, I want to give you a kudo for bringing this issue up, because bundled payment, probably, I don't know if everybody in the room knows what that is. The short version is that we have bundled together all of the services that are provided to dialysis patients and determine what the government thinks is a fair reimbursement to be able to provide those services and make a profit on top of that. But you're going to hear all sorts of things, that we can't give you certain kinds of treatment because the bundle won't let us. Well, that may or may not be true. So learning more about it is a very important thing. Thank you for thinking of that.
Okay, and the second part, even though he's giving us 10 points, we need those advocates' priorities that you had listed.
Oh, yes.
So is there any way we could get it in email or something? Because we need to know those things.
Yeah.
And I'm a first-time convention person, and this won't be my last time.
Again, my presentation also can be shared just like Paul is sharing his, and you can do whatever you want with it.
Okay, this is going to be our last question.
It's better. This isn't a question. I got a testimony about the AAKP website. You have a question about how to plan your diet, get your physician to give you a prescription for sodium, the amount of sodium, amount of phosphate, amount of phosphorus, and the amount of protein. And you go to the AAKP website, and it'll tell you, it'll direct you to a menu, it'll direct you to a diet thing. It'll give you a diet plan, it'll give you recipes, it'll give you a shopping list. And it's the best thing I've ever seen.
I'd like to add to anyone else who's interested in diet that we will have 2 sessions on diet tomorrow. There will be registered dietitians. And again, to reiterate what Mr. King said, please check out the AAKP website. If you don't have access to the website, call the AAKP office and you can receive information on diet and nutrition. I want to take this now, getting close to time for our next session. I want to thank our panel. Thank you so much for your time. Thank you so much for information. I wish we had longer because obviously what you talked about, everyone is interested in.
I got 2 minutes. I won't last long. I'm Bob Abbott, and I'm from Arkansas, and I want to thank you for coming. This is a fantastic meeting for Arkansas, and then I was just thinking, this is number 38, and this is also number 38 year that we've had the ESRD program. And I want to mention what Paul says here about you do have a voice. I don't think there would have been a program 38 years ago if we hadn't had an Arkansas representative up there. Now, let me tell you real quick, he wasn't in favor of this costly program. Wilbur Mills didn't go on record at first for this, but he had people from Arkansas putting the pressure on it. We had a great doctor that was a transplant doctor here in Little Rock, and he was a key part in that. I know lots of us wrote letters, and I just think this is great for Arkansas to play a part in the number 38. I hope you all have a good time.
Again, thank you everyone. Thank you to our speakers, and if you see them while you're at the conference, just grab them and bend their ear.
Oh, there you go. Sounds like a plan.
That's further down the line.
I'll be around though until Sunday, go back Sunday.
Oh, okay, good. Okay.
One thing that would be good to go to CNS here. I just mentioned it'd be great to go to CNS get, these folks, give testimony to something. How we going?